But I do remember a couple times when a patient came and told us their story, and I understood a little bit more about what is the process, how does it feel to be involved in the medical system? How do you deal with a life-threatening illness? And also, how does that relationship with your clinician, your physician, your nurse practitioner, your nurses, everybody, how does that go? How do you deal with sometimes really difficult situations? So we wanted to add this session or change our plasma cell experience to invite someone who's been through it at both the VA and here. So Dr. Hurst, right? He went to school at Vanderbilt, and he lets me know it a lot. He says that I went to the Vanderbilt up in North, which is, yes, I guess that is one way to describe my schooling. But he was very gracious to come here and be willing to participate. So I'm going to start the recording here. And it's bouncing a little. Thank you. All right, so welcome everyone to this morning's plasma cell neoplasm patient experience. And so you wouldn't mind introducing yourself, saying hello and how you met me, and then we'll go into some details.
Hi, my name is Bill Hurst, and I live here in St. Louis. I met Dr. Schoen after being having some abnormal blood tests at my primary care physician, who then referred me to hematology, who did further blood tests, who referred me to Dr. Schoen as an oncologist.
Yeah, so it was a little bit of an experience. And so just so everybody can sort of understand, how does this happen? How do we actually make a diagnosis? And so that's what this session is about, is to learn about the treatment from the patient and the physicians, to sort of experience the diagnostic odyssey. In medical school, we have these very narrow cases where they answer one question. It's rarely like that, in the sense. It's usually over a period of time you get information, and you have this sort of more of an odyssey and less of a flash of answers. And maybe that's just my field. I'm not a surgeon. I don't go in there and operate on people and get it over real quick. That's my choice. And so we have to. The goal of this session is to learn about what it's like to be a doctor and a patient, develop relationships, management of complex questions, and then also learn a lot about myeloma. And so if you have questions, please let me know, and we will be able to also sort of get them soon. Okay, fantastic. So, typical case question that we have here is a 62-year-old male with anemia. As he said, he went to his primary care physician. He had some rib fractures. He's evaluated by his PCP, and he's found to have the following lab values. And I'm learning. I'm getting the normals on there, and so I apologize for that. You can see that his hemoglobin was 9.4 when he first came in, and it was prior, 1.4. I got that messed up. The prior was 14, not 1.4. His creatinine was a little elevated at 1.4, and the normal was up to 0.2. But his calcium, his protein is normal, as well as his albumin is normal. And so we'll talk, about why those are sort of important in further discussion. He says that is the big deal right there. And so when you look over time, this is what his hemoglobin had been doing. You can see that his hemoglobin was at 14 and normal for a while, and then all of a sudden, something changed. And that's how this normally happens. Something's different. Hemoglobin went down into the toilet, down about into the 9s. And so, were you feeling much at that time?
No.
Not really. Okay. And that tends to, and then at the same time, his creatinine started to rise. And this VA changed their assay, and so they're on different scales. So you can see that I added the next dot up there, and so I drew that in. But that was what was happening. So as the hemoglobin was dropping, the creatinine was rising. And so, as you've learned from Dr. Kreisel already, when you think about anemia and renal failure, one of the things to consider is multiple myeloma, among other things. And so, what would we order next? Anybody want to shout them out? What do you want to order next if you're thinking about it?
E.
Yeah, you order A. Would you also maybe order B? Yeah, probably order B. Would you get C? Yeah. You get D? Maybe. Usually we make a diagnosis first, but you could get D. Could you get an E. Yes, if you're a primary care doctor, if you see a new anemia, dollars to donuts is probably iron deficiency. It's pretty common. So I would definitely do E, and then immediately do F. No, please. Please do your job. Don't just call me for everything. And so what happened is the primary care doctor just said, oh my God, sent it to me. And actually didn't send it to me, he sent it to my nurse practitioner first. But without even like thinking about it. So that's pretty common. So, just to sort of talk about these diagnostic tools, and I think that Dr. Price sort of mentioned some of these. These are the typical things, the tools that we have to evaluate for plasma cell neoplasm. And so we'll go back. But the main thing is a serum protein electrophoresis. And what that does is it takes the proteins and separates them along an electric field or a gradient. And you can see a monoclonal spike. And so it's represented there in sort of the orange is that you have this spike of a weird protein. And you can see that there. And what that's measuring is it sort of measuring that you have this abnormal protein present. You can also do serum-free light chain assays, which give you an estimate of how much of a certain kappa or lambda. But it doesn't tell you anything about clonality. Because in cancer, of course, is a clone, and so a light chain is just a measurement. You can do immunofixation. So once you have the proteins separated, you can then take the proteins and you can bind other antibodies to them to identify what the protein is. So it's an IgA, IgD, IgM. And then, so all these things together are what helps you to understand what is going on. All right, so what did you think we were going to see? That's the first time it was a nurse practitioner. My Dr. Thievery, or nurse practitioner Thievery, about this issue. How'd that go?
Well, when I went to see Ms. Thievery, I was sort of very unsettled because my primary care nurse practitioner did something that none of you should ever do, which is she told me lots of stories about people with abdomens full of tumors and people being rushed off to the hospital directly from her office. And she's a wonderful person. I still see her, but she convinced me that I was probably dying, and I felt like it was going to be any day. So by the time I got to see the nurse practitioner, that had sort of settled down a little bit, but I still had a feeling that it was likely that I had some kind of cancer, and she confirmed that. But she was much more calm and helped me, sort of understand a little bit more about what it was likely I had, and talked to me about next steps, which was bone marrow biopsy. I think was probably the next major thing that I had done.
Exactly, and I will sort of pause and say that is the number one problem, or one of the biggest problems with people who come to see me. Sometimes they have no idea why they're coming to see me. Or they're like, holy shit, oncology. Oncology means cancer, I'm gonna die. And so sometimes it's just their platelet count is 145, and it was a problem with the tube and something like that, and then they think that they're gonna die, and they show up to my office and all right, that. And so just in your practice, know that when you send somebody to someone, whether it's to see a surgeon for having heart disease, a neurologist for a movement disorder, or an oncologist for a cancer, think about what the patient might feel or think, and hopefully try and set them up for success and set me up for success. So that one, that they show up. Because half the time my patients are too freaked out and they just don't even want to show up. They're like, screw this, I'm just gonna die. I have a lot of patients that went through Vietnam and they're like, man, I got out of the jungle in Vietnam. I'm so happy that I didn't get shot or killed, and that every year since then has been a bonus. And so they're like, half the time they don't even want to know, they don't care. And so but that's one person's, one group of patients that I see that's commonly experienced. You will know that every patient that you see have their own individual experience that sort of dictate how they react to serious things. All right. So these are the blood results after she saw Valsa, nurse Thievery. the SPEC, this protein electrophoresis, was too small to quantitate. So there was not enough of the protein there to measure it. But the kappa and lambda was quite altered. And so this kappa was 6.9 in the normal range, but the lambda was 9,170. So that's way higher than it would normally be. And what's important is you look at the ratio. And that in this disease, you would sort of look at how, you should be a sort of a roughly equal number of kappa and lambda. So if there's a really high one of them, it means that there's something off. Now there's many diseases that can increase both. So if you have a lot of inflammation, they'll both be high. If you're a kidney failure, you're not clearing them, both will be high. But it's only if you have a process that increases one of them, such as a tumor, you get to have this finding where the lambda is through the roof, or a kappa is through the roof. And so you can see the ratio is kappa to lambda is 0.00075, but then the inverse of the ratio is 1,300. So either way, one is very much higher than the other, and that the normal is sort of around 1. But in multiple myeloma, we define, one of the criteria for cancer is actually a kappa lambda ratio of greater than 100 or less than 0.01. And so, why this is important? Why this is important is that these lambda light chains, or just in general the monoclonal proteins, can get stuck in the glomerulus and cause renal insufficiency. This is a picture from the New England Journal of that. They get filtered and they clog things up. They form these casts. So you get this cast nephropathy. And it's particularly common with lambda light chains. And so one of my mentors, not this one, but a different one, said lambda is lousy. And so I remember that lambda causing more kidney trouble. And so this is what I was mentioning about the criteria for multiple myeloma. There's multiple ways for someone to get diagnosed with multiple myeloma. These plasma cells, which is a clonal process, can cause a bunch of different manifestations. They can cause hypercalcemia. They can cause renal impairment, as we just discussed. They can cause anemia, as it did, as well as bone lesions. And so that's why we do a skeletal survey, or even an MRI or a PET CT. And this is Mr. Hurst's, or Dr. Hurst's head, just a plain old X-ray. And you can see that there's this hole right here. There's actually possibly there's a couple of them. And if we look throughout his skeleton, we did find a couple holes, and those were consistent with lytic lesions of multiple myeloma. So based off of our initial testing, which was an elevated lambda light chain, and then as well bone lesions and anemia, we're like, uh-oh. Again, smells like there was something rotten in Denmark. So where is Denmark? We do a bone marrow biopsy, and we asked Dr. Kreisel to help us out. So when you heard her do a bone marrow, what were you told about it, or how did it go?
Well, I had one of you do it, so it wasn't that great. I'm sorry to say, no, it wasn't really one of you. It was a fellow that did my first one. And at the VA, different from SLU, I've had a couple at SLU, and at SLU, they give you lots of medication. And so it's really not a bad thing at all, because you get fentanyl and that Ativan, and so you don't really mind getting a bone marrow biopsy. At the VA, they give you local anesthetic and tell you to grit your teeth. So it's not as fun. But initially, when I heard about it, I thought, from my childhood, bone marrow biopsy means spinal tap, and it's something that's really painful and something that you really don't want to do. I found out that now that I've had 3 or 4, that they do it in your hip, and it's much less invasive and not nearly as bad as it used to be.
It also depends
VA
on.
needs to learn from SLU.
Well, yes and no. We have not had a anesthesia complication at the VA, but it is true. Bone marrow biopsy can be a difficult procedure. There is a lot of operator dependence, and so sometimes the lidocaine can be put in a different spot where the bone marrow biopsy needle goes, and that is, yes, not ideal. And so there are certain operators that are better than others, and so we try to teach that skill. But to move on, so this is what the bone marrow morphology looks like. So at this time, we're actually sending, at the beginning, we were sending it out to outside laboratory. We didn't have our in-house people at that time. And so we did something called immunohistochemistry. Dr. Kreisel is an expert in that and other stains. So you can see that this is a report. The iron stain, they always do iron store stains are present. Congo red shows that there's no amyloid deposits. But the CD138, and so CD138 identifies what type of cells? Plasma cells, of course it says gram-positive plasma cells right there. So CD138 identifies those plasma cells, and you can see that this is what a normal bone marrow, oh not, this is his bone marrow, it's pretty packed. But then you look into this CD138, and so an immunohistochemistry stain stains brown. And so you look at that and like, oh man, there's a lot of brown. That's bad. Normally it should be less than 5%, but there's a lot of brown there. And so you see both of these, that high percentage of brown uptake means that there's a lot of plasma cells in there. And then just to go over some of the other cell types, CD3s is a more of a T cell stain, CD20, you know, is more of a B cell stain, and so they stain for other things, and really, there's a 138 that was positive. And then we've talked about flow cytometry, they also do flow cytometry on it, and they say a bunch of monoclonal plasma cells are detected. And so, as we talked about before, you can put markers onto cells that are fluorochromes, and that the fluorochromes will show what things are on the person's side, what is present on the surface of the cells. And then also you shoot lasers at the cells, and you see how big they are and how complex they are, and it allows us to differentiate the cell types. And so we have mainly still lymphocytes, 35%, some monos, these are not granulocytes, but there's 2.6 plasma cells in this sample. So actually not that high, and that always happens with our aspirate, is the plasma cell count tends to be lower, but it shows that it is lambda light chain restricted. And what should plasma cells have? Should have an equal amount of lambda and kappa. And so therefore, because they're lambda light chain restricted, and it's more likely to be a malignant. And of course, you see at the bottom, they tested all these markers. So I have no idea why they did a CD11C and all this kind of stuff. I think they probably bill by the number of markers that they do.
Well, I guess you don't really know beforehand what you will be expecting, so you keep your, you keep your panel quite open so that you really have everything.
Although I said rule out myeloma on my requisition
Yeah.
sheet.
But it's also better for our flow course, because you don't want to have all these different panels. It gets very confusing, and maybe you're wrong.
Yes, I frequently am wrong, as Dr. Boyle will tell you. So, what are your thoughts about coming to see me now that you had this bone marrow? You looked some stuff up, I know. I remember that you looked some things up before you came to see me.
Yeah, like he says, I have an advanced degree, and so I'm immediately, and my wife is a researcher to no end. If she doesn't know something, then she goes crazy trying to find out. And so she looked a whole lot of stuff up, internet and Google searches and things, and I looked some up. But I think I was more just wanting to sort of, maybe it's a male thing, bottom line, what are we going to do about this? Let's move on. She wanted lots of information. And so when I first came, I had basic information, but I was looking for a little bit more, but mostly knowing, what's the process, what's my life going to be like for the next, however long this lasts.
It's time. Does anybody have any questions, possibly? Or, we've talked a lot. I don't know if anybody had questions about going to see the oncologist. Yeah?
What's your background? How do you feel like that affected? Do you have any background in the medical field? Or?
No, I'm humanities. You guys are way smarter than I am. I taught speech. So you all know a lot more, but because I have,
So he met me, and then I told him that this is likely going to be a long process. We're going to get to be good friends because it's a marathon. Multiple myeloma is a disease that we rarely cure. There are some people that have cured, but really it's a chronic disease. And my goal is to help people live, of course, the longest, best life they possibly can. And we have a lot of tools in the toolbox now. We didn't used to have a lot of tools in the toolbox. We have a lot of tools in the toolbox now. So, that's me. And so, I did want to sort of mention, like, when you think about multiple myeloma, it's one of the weird diseases where you can live with it kind of for a long time in the sense that you have these clonal plasma cells that are derived from immature B cells. So these cells grow up and they become long-lived plasma cells, and that they usually provide a whole bunch of antibodies, and they prevent you from getting infections like COVID or whatever else. But sometimes they can go a little wrong. But if they go a little wrong, they develop this monoclonal gammopathy. Actually, it's not that big a deal. You can have a couple plasma cells that really grow a little bit more than they should, and they just produce this protein, and it doesn't bother you. It doesn't cause any trouble. But what can happen is that the cells continue to grow, and they start causing trouble. And that's when it develops into multiple myeloma. And that we don't really understand all of the development of myelogenesis. There are many ways to develop these abnormal plasma cells. You can see that there's a lot of genetic events that are listed in this summary slide from Pinto et al. There's primary genetic events, secondary genetic events, a bunch of other mutations. But also, what we're actually kind of learning, and more recently, is that it could also be a failure of an immune entity. That our immune system sometimes clears out these abnormal cells and gets rid of them, and that your body can sort of handle it. Because this probably happens all the time in our body, and that sometimes the immune system just doesn't get rid of what it is. And so hopefully down the road we can treat myeloma with more of immune modulation and getting rid of it. And we've already moved somewhat that direction, but we're not quite there yet. And so what we do, always do when someone comes in is, since we want to know, like, well, how much of a marathon is it going to be? Is this marathon going to be like a 10-year marathon? Or is it going to be a 5-year marathon? So we do a risk stratification. So I will be asking you to use your computers and phones in a moment, and so just get those ready. But the first thing that we do is we do a cytogenetic study, which you see in these chromosomes, and that you want to know, are the chromosomes normal? And that this is a 46XY, so your chromosomes were normal. We didn't find anything weird in your chromosomes. We then did a FISH, which is a fluorescence in situ hybridization, which is a more sensitive measure of finding alterations. And we only look for specific mutations in this one, or specific translocations or abnormalities in FISH. Versus the chromosomes, we're looking at the whole chromosome. Versus this, we're looking at FISH. And we did 1P, what's the 1P, 17P, 414, 1114, all of those, none of them were detected. And this is what it looks like on a FISH panel. This is your FISH. This is the analysis. And then you can see we did test all this stuff. We didn't find anything. So, based off of this, we had normal cytogenetics and normal FISH. And that this is what we're going to, is I'm going to the myeloma RISS. So your beta 2 microglobulin was 6, LDH is 191, LDH is 4.5. So if everybody can Google or otherwise search myeloma RISS, and let's see what we find. Because guess what? This is what you probably will do in a lot of your life. It's like, what's the prognosis? Because that's probably the first question you get. Like, how long am I going to live? And so this is one of our tools, and it's a crappy tool, but it's what we got. All right, so is anybody pulling it up? I will do it here.
While they're doing that, I would say that that's a big difference between my primary care and Dr. Schoen and ultimately Dr. Doyle, was whereas she convinced me that I was about to die any day, they both were, very much, we can handle this. This is not something we haven't done before. It's a marathon, not a sprint, which I put on a t-shirt. But still, it is a marathon. It's something you can run. You can do this. And so, their attitude was so much more positive and so much more encouraging, that helped a lot. facing the next stages.
So that is our goal, is that this is a relationship, this is time. So when you look at the RISS, MD Calc has it up there. You can get the beta 2 microglobulin is high, calcium is high, beta 2 microglobulin is high, serum albumin was normal. There was standard risk in the sense that there was no cytogenetic abnormalities, and this does require a little bit of interpretation to know what is normal. And then his LDH was also normal. So he's stage 2, which says at 42 months median progression-free survival. The only risk factor that he had was this beta 2 microglobulin. If I click stage 1, it's slightly better. But as we've talked about, like, a lot of these markers are just not great. And so what I tend to do is that I tend to talk about it, and I sort of show, you know, I didn't show this at that time, but we know, like, which curve do you want to be on? And, like, where do you, like, and of course, everyone wants to be on the pink curve, but we have to deal with what we have. And so his diagnosis was stage 2, so he's on that green curve. So it's definitely in the, at least 8 years, and that's likely even longer than that with a new therapy. Because when this RISS came out, we actually had even crappier tools. Because when you think about, like, in order to, we had to follow patients for 16 years almost. So whatever this, when this published tool is published, it was like the patients were started on treatment 16 years ago. So I always tell people, this is probably the lower bar of the average. That in general, it's probably going to get even better because we have new drugs, new techniques, everything is better than it used to be. So this is sort of the lower floor for him. Okay? And so, I know this is a lot of stuff. So how did this all come across?
Well, I guess, like I said, my wife probably knew a lot more about what my prognosis was than I did because I focused on just surviving. And I discovered after I got my diagnosis that I have a cousin who has kappa cell myeloma and has lived with it for 15 years. So that was kind of encouraging. She's 15 years and she's kind of treatment averse too, so she hasn't had a lot of treatment in those 15 years, and yet she's still alive. And so those things sort of helped me. The fact that you all kept saying that this is really more like a chronic disease than a terminal disease. Even though it's terminal, but we treat it like it's chronic, and so that I figured, I can live with taking pills, I can live with going to the doctor and having blood tests, as long as I can live, and that's important.
Any questions, comments? I find that this is the toughest part, is that when someone first comes in to see me, they don't really know me yet, they don't know what's going on, they don't know what the treatment's going to be like. They've heard about cancer and chemotherapy, and all they can think of is, like, what's seen in movies, and trying to sort of say, trust me, we're going to get through this, and that, is a tough thing to do. And, thinking like, well, I may only have 10 years. It can be tough.
The stereotype of chemotherapy too, and all of that. You see, I lost all my hair. I didn't have any hair.
We'll talk. The trick is don't lose your hair on this one. Not until you get to the
I didn't lose my hair until I saw Dr. Goyle. Goyle was the one that stole my hair, what little hair I had left. But that really that's frightening, and that's helpful too, because the stereotype of chemotherapy is you're nauseous all the time, you have diarrhea, you're losing your hair, you lose weight. As you can see, my cancer plan as a weight loss did not work. I didn't lose weight at all. In fact, I probably gained since I first started this. And I had very little of those sort of traditional side effects that you fear. And having the doctors tell me that was helpful. Say, no, people tolerate this very well. And I had little things, that came up here and there. But to be told, you're not going to suffer, you're not going to be sick for weeks, and all of that was very encouraging.
So this is his initial treatment, and that we gave him. It's called VRD. Really was been created in the last 20 years. V, which is really actually bortezomib, is the generic name. This first sort of came on the market, or was proven in about 2002, 2005. Actually remember it when I was a med student. And then lenalidomide also came on a little later, but both of these medicines are new in the last 20 years, and they really have been helpful. And they've been tested in randomized trials to just look at survival. And so we use a triplet or we call it a triplet of bortezomib, lenalidomide, and dexamethasone. And about 3 years ago, we tried to improve it. We gave a newer version of bortezomib called carfilzomib. And this is what the figure is on the right. This is from the Endurance, maybe it's Endeavor E something trial. But this is how we decide if things work or not. This is how I decide if things work or not, is that does it make you live longer? Does it make you feel better? And we tried to improve upon it, and it was not any better in how you live or how long you live or how well you feel. That's why these curves are sort of overlapping. And we give that for 4 to 6 cycles and try our best to sort of improve and get rid of as much myeloma as we possibly can. As I learned from a different pathologist, myeloma cells or plasma cells are like cockroaches. It's like really hard to kill them. Like when we do ablations for acute myeloid leukemia, we give people something called 7-3 and we destroy it. You know what's left in your bone marrow? A bunch of plasma cell cockroaches. And so it's really hard to get rid of these things. And so we try hard, but you just can't eliminate them. And so, yes. Okay, I'm going the wrong way. Sorry. All right. And so, this is a sort of picture of like, what does bortezomib do? Bortezomib inhibits the proteasome, and it inhibits the destruction of the proteins that are created by the cells. And we have all this like elegant chemistry that says, look, all these myeloma cells are producing all these proteins, and it's gumming up the cells, and that it causes, if you inhibit the proteasome, it causes the cells to lyse. But to be honest, I don't give a rat's about what molecular pathway it's using. And this is my bias, and if you'll hear this, from me maybe one or two other times. These pictures are wonderful, and they're good to like get your drug into like a trial. But what I care about is phase 3 trials, and I want to know that I don't care what mechanism it could be. It could be like the sexiest thing ever. Like, this is going to bind to this protein, and it's going to attack that thing, and it's going to like have hair on its head, and it's going to ride a motorcycle. I don't care. I want to know: do you live better and live longer? And that's what I care about. So I don't get seduced about this. And so you can see that in the randomized trial, this drug, trying to get my point over here, this drug, when you look at progression-free survival at the top, that's the survival without cancer, improved how long you live without cancer. And then also it improved your overall survival. So that's my marker of whether it's great, is does it make you live longer? No, I don't care what the mechanism is. To be honest, half the drugs we don't even know what the mechanism is. Like we do these confirmatory trials, and half the time the target is wrong. It doesn't matter. All right, but this is what we do for treatment response. So myeloma, again, it's really hard to get rid of it. So we have this really complex grading system called, I don't even know what it's not, International Myeloma
Working group.
Yes, International Myeloma. Like, to be honest, I just try and get the drugs in, and this is stringent CR, VGPR, PR. Like I have to look it up every time. I can't remember it. But with these treatments, you can increase the depth of response. And so what I would say is, if you look at this figure right here, you can see that ideally you want to be in the red. This is CR. So after VRD induction, you can have CR with 33%. But here's where we get to the next step, is that then if you go to a transplant, you can get even better outcomes. You can kill more cells. So that's why I decided to phone a friend and ask Dr. Boyle, or ask our SLU transplant team to sort of see what they think. And I don't know if you had any thoughts when I said, oh, I'm going to send you to SLU for a possible outpatient transplant versus other locations that you could have gone. I know that you had some opinions about to me the first time.
Yeah, I did. It comes from being uninformed, I think, partially, or informed only in a limited way. Because initially, they also do this at Barnes, of course, and at Barnes, the whole transplant procedure is done inpatient. And I thought, that's what I want, because I don't want to be sick, I don't want to have chemo and be feeling miserable and be at home and throwing up and not eating and just, just put me in the hospital and leave me there. Dr. Schoen encouraged me to come to SLU, because he said, I think you'll be much happier. And after I talked to Dr. Boyle, she confirmed most patients do much better if they're at home, and you're not going to be sick like that. And so I spent the majority of my time, or much of my time, at home, and then only in the hospital for a limited amount of time when I had, no immune system whatsoever. Then they put me in the hospital and watched me treated there.
So I'm going to turn a little bit over to Dr. Boyle here. So Sugun Boyle has been a mentor of mine for many years, and she is the director of our bone marrow transplant program here at St. Louis University. And she described just a little bit. I have a little graphic for you to sort of say what happens. But I don't know if you want to have a couple words about what the prep process is kind of like.
Do that. All right, so our team hears us say this over and over again, and we all say it the same way. So basically, the whole concept of an auto transplant, stem cell transplant, bone marrow transplant, all words we use interchangeably, is that we are going to take high doses of chemotherapy, something we did not give him to get him into remission, and try to kill off what Dr. Schoen describes as the cockroaches, every last one of them. We can't kill them off once and for all, because that's cure, but we can kill them off for longer than that VRD, that triplet, that he got before the transplant would have done on its own. So we tell our patients, if you kind of are sent to us, our first step is, are you eligible for one of these? You have to have disease that isn't growing out of control. He didn't, he was already responding by the time he came to us. He has to be healthy enough to tolerate the high doses of chemotherapy. And then we've got some of our social work team here too. He has to have an adequate support system to get through this intense procedure, and especially to be able to do it outpatient, because we rely on his report of symptoms to keep him safe. So when we clear all that, they basically become their own, they become their own blood donor, but they donate their own stem cells, blood-forming cells, rather than red cells or platelets, as some of you might be used to doing if you were a blood donor. We actually have the ability now, we don't call it a bone marrow transplant, we don't take these stem cells from the bone marrow, we actually take them from the blood. So we give high doses of a white cell stimulating hormone called GCSF. We're able to get those cells not only grown to higher than physiologic numbers, but then pushed or mobilized from the bone marrow into the blood. We do those shots for 4 days, and by the 5th day, they go on a machine where they effectively look like a blood donor. Machine spins out or takes out their blood, spins out their stem cells, returns the rest of it back into them. Those stem cells go into a freezer until we're ready to actually start the transplant per se. And the transplant is really high doses of chemotherapy, in this case 2 days of high doses of chemotherapy, followed by on that 3rd day what we call autologous stem cell rescue, or the stem cell infusion. We put those stem cells back into them to basically be able to support their blood counts, because the high doses of chemotherapy that are intended to kill those residual plasma cells will kill off all their blood forming cells in the process.
Questions?
Can you tell us what those 2 days were like of the chemotherapy?
Again, it's really simple. I mean, it's just like having a doctor's appointment. And that's one of the things that I hope that people will get from this, and that if you're in a position to talk to someone, it really, for the most part, is painless, and it's just like going to the doctor and giving blood or getting getting a shot. There are some side effects connected to it they warn you about. The chemo can cause a lot of, can cause you to have sores in your throat and mouth, which can be really severe, and so you have to do things to prevent that. The medication that causes your your cells to grow can cause a lot of bone pain because you're taking what was your normal amount of bone marrow, and suddenly you've got this little space and you're getting 10 or 20 times as much in there, and so it's pushing on your bones, and so you can have bone pain from that. But the process overall was very easy. My wife was with me all of the time except for the actual stem cell collection was the only time that they would let her be in the room. And so it's boring. I mean, it's just routine, and not difficult. It's psychologically difficult. I guess that's something that I wanted to say, and I know that our time is getting close to being over too. For me, the biggest thing that I hope that you all learn is that it's not just about the medicine, it's about the psychology. Because that's what I continue to deal with, and that's what you deal with when you talk to the doctors. They're talking about survival rates and telling you about what's going to happen with this medication and that medication. And most of the medical side of it has been pretty easy, but it's living with the disease. There's a commercial for St. Jude Hospital that I see now, where a little girl says the hardest part about having cancer is knowing that you have it. And I think that's the hardest part of the whole process, is knowing what's going on and realizing that you're getting medicine that's designed to kill all your blood cells. Knowing that there could be side effects and all that, living with that reality. Knowing, in my case with multiple myeloma, that it almost certainly will come back. And wondering whether that will be, in 2 years or 5 years or 8 years or 10 years, but knowing that it's going to come back.
So as we sort of described, we use this medicine called melphalan. It's an alkylating agent. It's very similar to a lot of other ones. So you can see that this is the business end of the molecule where these chlorides are. Similar to cyclophosphamide, etrimustine, farnesyl. And it links DNA, sort of. And so I bring this up to sort of, that this is how this cytotoxic medicine works, is it cross-links the DNA, you can sort of see the guanine bases, and then interrupting the cell cycle. And so it's a little bit more of a traditional chemotherapy. Again, I only care if it improves your life. Sounds cool, but it's gotta make you live longer or feel better. So, alright. And so, wrong slide. Alright, so that's the goal of this, is that she's gonna kill any remaining cells, get into a deeper remission, longer time to relapse, and that without the stem cell rescue, that's really what this is that without the stem cell rescue, we would die from infections because the chemotherapy is just so much. And so I kind of sort of consider this to be a control alternate delete. Like we're sort of rebooting your immune system, we're kind of killing it all off, we're gonna start over. So the cells have to relearn what to do. Sometimes we actually can get some autoimmune disease. It's less likely when it's your own cells, because we actually had some case reports that Dr. Goyle and I have published about how you can develop autoimmune disease. But also you have to give people, after this, all of their vaccinations back. Your body has to relearn how to fight all the normal stuff. And so it has been really difficult in COVID to do some of these things because you are at higher risk of infections. And then yes, Dr. Goyle told Mr. Hurst that she's better than me. And it's true, she is. We know. But we can't all be,
I gave her a 5-star rating on Google. I didn't know if you could. I wasn't aware that you could rate your oncologist on Google, but I found that you could. So Dr. Goyle.
And that's why I work at the VA. You don't have a choice. I get a lot of 3 stars if they had a star rating, but I don't know, you can't find me. All right. You sort of already discussed your transplant thoughts, so we'll sort of skip to the next one. And so after the transplant, we do maintenance therapy. Because this disease has a tendency to come back, that we want to sort of put some pressure on it to sort of prevent that from happening. And while we have a low amount of cells, we sometimes, maybe it'll be a really long time. And we have this medicine called lenalidomide, which, again, when you look at this picture, you're like, this medicine does everything. It does like this and that, it does all this stuff. And of course, when you see a picture like this, again, this is my biases. I'm not a molecular person. I'm like, that means we don't even know what it does. It does all this stuff we don't really know. And so, what I'm hoping it does is it gets rid of these light chains and heavy chains. I want to know that these light chains that are represented in the blue and the heavy chains in the green, that they stay away. And so, I don't care about that. I do care about this, that it helps you live longer, and that it makes you hopefully feel better for a long period of time. We actually have some trials that are looking at how long you should take this, because after a while, this medicine does get a little tiresome. It does have some other side effects, and so we
Mostly what it does is give you diarrhea and make you tired. That's the main effects of lenalidomide.
Yes. And so that's what you're on right now. The lenalidomide. And I wish we had a better tool, but that's what we got. And so I didn't know if you had any other summary or any other statements or any other questions. I really appreciate everybody sort of listening, but any statements, like what else would you take out of, what would you recommend for the second year students to take away from this?
Well, like I said, I think the main thing that I want you to know is, first of all, don't be like my primary care physician or nurse practitioner and convince your patients that they're going to die. Be like Dr. Goyle, Dr. Schoen, and convince them that they're going to live. It's much better. And realize that you do have to be much more than just a scientist. This isn't really, and I don't think it just applies to oncology, it applies to everything. It's a whole lot more to being a good doctor than being a scientist. That's part of it, but dealing with people and all kinds of people in all sorts of situations and helping us get through it. I mean, I'm going to go see Lisa if she decides to come to work on Tuesday next week, I think it is, and I'm going to get like 8 vaccinations. So it's not fun. That's what I have to look forward to for the next 2 years after my transplant, is going and getting all of my vaccines over again. And then if I get sick again, then I'll have another transplant and have to do it all again. So sort of keeping us going, that's what I need more than anything else, is just that continued encouragement and pushing me to know that, it's a process, and it is a marathon, it's not a sprint. But that, that I can do it. And, they've done this before, and, I'm not the first person.
I think everything Mr. Hurst said is, Dr. Hurst said is important, and I think our whole goal is always that. I don't think we ever are in the business of trying to give false optimism, but we do want to correct myths and kind of media impressions that I think all of our patients come to us with. There's so many patients who come to us and turn down chemo, turn down transplant because of what they've heard about it, and it is very important to be patient and to not judge that opinion that they come to us with, because that's all they've known before they deal with this diagnosis themselves, and we have a whole team to help us out and support patients through that. And so I am grateful for that and our colleagues, and it's a good field.
Yeah.
Everybody should do it.
Yeah, that's exactly why my cousin, who is 15 years into multiple myeloma, has never had a transplant because she heard horror stories. And she just said, I don't want to go through that process. I won't do it. And I told her, it really wasn't that bad. You know, I was in the hospital for 11 days. I got pretty sick. I didn't eat, you know, it wasn't fun, but it certainly was worth doing because it could save my life. And so it was purely her, you know, fear that has kept her from, you know, getting treatment that she could have gotten to do even better. She has lots and lots of side effects from long-term use of, you know, these medications. I think she suffered a lot more than she probably had to if she got past her fear, had a doctor who helped her with that, so that she could have gotten better treatment.
Any other questions before I sort of conclude final statements? Any questions? Well, yeah, you know, I hope that you take from this that like I really love what I do, and I know that Dr. Will and the rest of the team that's here to support, you know, the patients. I find that, you know, I love this field because it takes such advances in science, some of the coolest technology, and is able to sort of help people in sort of the worst time, and it also, you know, has this human component. We're dealing with a serious illness. We're using some legitimate, dangerously toxic medications. So that combination of the science and the humanity, at least for me, makes this field wonderful. And it's the type of medicine and physician that I still want to become. I'm still learning and trying to become. So I really appreciate everybody coming today. I hope that this patient experience was worthwhile. You know, we'll be up here, or I'll be up here if anybody has any questions. But I really thank you for being engaged and paying attention. And yeah, thanks so much for your attention.
Thank you.